18, the therapy is 2 months of intensive phase HRZE, followed by 4 months of continuation phase, which continue HR and Combitol. Thank you.
And I'm going to address them.
Yes.
Yeah, this is for this is from just hold on. From Dr. Nikhilesh Yandamuri. Oh, sorry, not a question. Second is from Dr. Sanchit. How can we differentiate proximal small bowel from distal small bowel obstruction in intestinal tuberculosis? And differentiating between lymphoma and TB clinically.
So for proximal small bowel and distal small bowel, he's asking on clinical features. So proximal small bowel would be more like predominant vomiting, upper abdominal discomfort, the colics. While for the mid to distal small bowel, the pain would be in the periumbilical region, the colic, and it would be more of distension, some vomitings. So this is a clinical. This has nothing to do with tuberculosis. Whatever stricture it is, proximal would have more vomitings, less distension. Distal would have more distension, less vomitings. Lymphoma versus TB clinically, all those things would still play. So if you're talking about lymph nodal lymphoma versus tuberculosis, you would need sampling. CT may, to some extent, differentiate. Necrotic nodes are more commonly seen in tuberculosis. Otherwise, you need to sample the nodes. FNAC, more likely biopsy. Take good sample by whatever means it is, and if not feasible, the whatever means can be looking at cilia, axillary or cervical nodes, taking a surgical biopsy, EUS guided 19 gauge needle biopsies, and in certain situations even laparoscopy with biopsy, lymph node sampling may be needed. In case you are asking me to differentiate GI lymphoma versus tuberculosis, it can be difficult. Have a strong suspicion. Take biopsies, even from small bowel, ask for an enteroscopy and take biopsies. In case not making a diagnosis, again, go for laparoscopy and evaluate thing. The composite reference standard is from a paper published this year, where they are trying to standardize the talk. So this is not something which I'll say is uh, the short form CRS can be used in your papers or in your day-to-day go. This was a concept to just talk on how can you make a diagnosis of tuberculosis? What can you clinically talk on that?
Right. So, what is the role of fecal calprotectin in intestinal TB? Dr. Sanchit is asking this
Fecal
question.
calprotectin is a test which picks up evidence of inflammation in the bowel. Is it tuberculosis? Is it giardiasis? It is Crohn's? Is it ulcerative colitis? Is it amoebiasis? It does not talk about that. So if you are looking at IBS, functional versus organic, fecal calprotectin is the go-to test. If your differentiation is intestinal tuberculosis versus Crohn's, don't talk about this. If you're already aware that there is inflammation in the bowel, don't talk about this.
Okay. Now, Dr. Dipen Agarwal has asked, what is the sensitivity of adaptations? I don't understand the question. But if Dipen is listening, can you ask the question yourself? Dipen, I don't know whether he is still around.
Hello.
Yeah,
Hello.
yeah, Dipen, please.
Yes, sir. So sensitivity of ADA, especially in TB CLD patients, sir. TB with CLD.
So you are talking about ADA.
Yes, sir.
I've already talked about it, Deepen. In situations where your cell-mediated immunity is likely to be low, which would include cirrhosis, which would include HIV or chemotherapy, the sensitivity of ADA is low.
So should we go for ADA in TB with CLD, sir?
Yes,
Or
go for it. I never said that the specificity would be low. So if your TB CLD patient has a ADA value of 60, this is definitely tuberculosis. The problem would arise when the ADA value come out to be 18. What would you do then? You cannot say based on ADA value in a cirrhotic that this is not tuberculosis. The problem is there.
Okay, thank you, sir.
So I have a question for Dr. Bibu. Dr. Bibu, ADA values were the cutoff values were given by All India Institute Group and Vellore Group, and they differed somehow in the SITs. What is your comment on that? What
I didn't get you, sir. The values were given by All India and the Vellore Group, and
were different cutoff values, and they
yes.
were markedly different.
So, so it is a ADA is a test which has a continuous values, and the as I said, sensitivity and specificity would depend on the prevalence of that disease in that group of patients. Like if you like if you take up American papers, the sensitivity and specificity and hence cutoff is markedly different from what the papers in India are. So it is not about a particular group giving a particular set value. It is more about the concept. So it would depend on what exactly was the prevalence of tuberculosis in that subgroup.
All right. So what are we following now? Are we following All India Institute values or Lal's lab, or most of our samples go to corporate labs only?
So certain papers say more than 30.
Yes.
Okay? But then it would depend on what your patient population is.
Mhm.
So I would not immediately label 34 as tuberculosis. 60 for me is definitely tuberculosis. So it adds. So it is not a definitive test. So I'll never say that based on ADA everything should be done. So only test needed is get an ascitic tab done, get the ADA and forget about it. No, it is not. It is one additional test, a good test, which helps you clinch diagnosis in some patients.
All right. So it is again, its value is only corroborative and not definite.
Yes. It's not a gold standard.
Yes, not a gold standard. Now, the next question is from Dr. Ajesh. What is the role of TB PCR?
Rajesh, I have stopped sending TB-PCR. The go-to test these days is Gene Expert, which I was referring as Expert MTP oblique RIFSA, and I've already discussed about it. This is around 25 to 30% positivity in ileocecal tuberculosis samples. The care which you should take is the test field is already too bloody. The chances of this being positive even goes down further.
Okay. My question, my query to Dr. Vibhu once again, the gene experts only determines resistance to rifampicin.
Yes, sir.
So, what do you think? Is there no resistance to INH? And
No. So the so number one is rifampicin is a so again this is a microbiology question, but the as per my understanding, rifampicin is one of the most important drug or armamentarium for tuberculosis, and development of rifampicin resistance is holds bad for the overall prognosis of the patient. The point is, it is looking at a fragment of gene which is involved in rifampicin resistance. So it is doing two things simultaneously. Number one, it is identifying that this is Mycobacterium tuberculosis gene, and on top of that, it is also picking up that genetic resistance. So that is the advantage. It is not to say this does not pick up INH or O. This test was designed such that it can pick up rifampicin resistance.
right. So, so in the same note, can you tell us something about prevalence of resistance? Because we see a lot of MDR tuberculosis in pulmonology.
Yeah.
So what
So,
about abdominal?
so yes, 2019 AIMS paper talks on resistance, 4 lines. Ossibacillary tuberculosis, the reported resistance levels everywhere, wherever it has been done, is less than 5% for abdominal tuberculosis. There was some paper from Korea which said 14%, but many of their patients had simultaneous pulmonary coughs. So when you have extrapulmonary and pulmonary tuberculosis, yani ki multibacillary tuberculosis, the chances of resistance usually is higher. Most of the papers do not talk about much about resistance even in 2020 in abdominal tuberculosis, pure abdominal tuberculosis. It is a possibility.
So is it rifampicin or INH, which is most susceptible to resistance, developing that?
I'm not the right person to answer this.
Okay.
The what I understand is rifampicin was picked up on this test because the gene it is picking up is rifampicin.
Yeah.
Also deals with rifampicin resistance. That is the only logic.
Okay. Now, I depends question. What is the difference between gene expert and TB PCR? I think it has already been answered. The other question is, how do you differentiate between Crohn's stricture and TB stricture, especially in small bowel?
So it cannot be differentiating Crohn's stricture and TB stricture, something new on that. Whatever I have talked about is nearly the same things. There is nothing new on Crohn's stricture versus TB stricture. Yes, there are two other situations: active TB stricture versus a fibrotic stricture. Number two, TB stricture versus lymphoma versus adenosine. These are also two pertinent points. In case of doubt, for Crohn's, I have talked already whatever I had to talk. But in case of doubt of malignancy in a short stricture, do take biopsies. Even after negative biopsies, keep a low threshold for dilating and taking repeat biopsies or asking for a laparoscopy. This was in comparison when we are dealing with a short stricture, which could be TB versus adenosine lymphoma.
Okay. What is the role of anti-saccharomycin and
No role, no role, zero,
diagnosis of Crohn's?
no role.
One of the questions is from Dr. Arun Gaiwali again, and I'm adding another query to it. He's asking what is the role of steroids in tubercular stricture, and my query is that is there some evidence in the literature to say that steroids can reduce formation of peritoneal bands, fibrosis, or they will help resolution of tubercular stricture faster?
Sir, so there might be viewpoints. Steroids might help in this or help in that. Number one, standard of care: no steroids for abdomen. Steroids for abdominal tuberculosis. Whenever you talk of tuberculosis and talking of steroids, you only talk of peritoneum, you talk of eyes, and to some extent pleura. The problem with abdomen is if you're differentiating from Crohn's, you're doomed. The patient would improve because you have already started him on steroid, and it would not be a diagnosis which could be made there. The literature does not support any of this use.
Right. So the answer is in present day practice, there is no proven role of steroids. But I would certainly ask another question following this. Most of the time, we end up in confusion when we see small bowel or large bowel pathology, and we are not able to distinguish between Crohn's disease and tuberculosis despite our extensive workup. Now, the question is whether we should start ATT alone or ATT with mesalamine or budesonide or treatment for Crohn's disease together, or treatment for Crohn's disease to start with and add ATT if we fail. Dr. Vibhu.
Sir, never combined therapy. That's why I said no steroids, because once you improve, you don't know what to stop. So I've shown a algorithm which says in case of doubt, give ATT first. Why ATT first? Suppose you are dealing with a patient of tuberculosis wrongly treated as Crohn's, you would have started steroids and would have worsened the patient. So giving steroids without ATT would definitely worsen the patient. So no treatment of Crohn's till you are not sure that this is Crohn's. Starting mesalamine and budase. These are medications with which are not so efficacious even in managing acute episodes of Crohn's. Especially mesalamine. Budase to some extent can manage mild Crohn's. So the literature as well as my practice would say, if in doubt, start ATT. In situations where you are reasonably sure that this is Crohn's and unlikely to be tuberculosis, you can start with Crohn's treatment straight away.
Right, but you will agree that there are instances when we are really caught up in this dilemma. If the disease is mild, Crohn's is mild, then we can wait. But if there are cases like fistulizing disease and fear of perforation, intestinal obstruction, then these decisions sometimes become very difficult. We have resorted to actually ATT in addition to steroids. Under cover of ATT, we have fallen on the side of Crohn's disease, treating Crohn's disease, but under cover of ATT.
Okay.
Dr. Nitin Bhople is asking, in a routine case, which we often encounter, patient comes with abdominal pain and we do colonoscopy, we find multiple ulcers on IC valve, ileal thickening, ephthous ulcers in the ileum, but the histobiopsy shows non-specific ulcers, no granuloma, and nothing positive for tuberculosis. Now, how do you manage these patients? You can't even call them Crohn's disease?
So in case there is significant disease, so there are two things. One is if it is significant disease or not. If there is significant disease, I'll start after evaluating and not fitting into Crohn's, I'll start ATT. If it is not significant disease and you are ending up only with aphthous ulcers or things like this only with minimal symptoms, this would require further evaluation, maybe capsule, etc. also. But if there is significant disease, as Nitin says, ileal valve involvement, IC valve involvement, with biopsy which are non-contributory, it is worthwhile starting ATT in these patients.
Okay, so I just have a suggestion in this particular situation based on a series from All India Institute. I do not remember the details, but in a sizable number of cases, which they followed small intestinal ulcers, the patient did not turn out to be tuberculosis, nor they turned out to be Crohn's.
So that series was for aphthous ulcers. So this is what I was saying. So if there is a significant disease, if you're talking about IC valve involvement and ileal ulcers, significant ulcers, start on ATT. And if there is non-significant, few aphthous ulcers seen here and there, patient symptomatic, ask for capsule endoscopy, there might be ulcers inside also. And if the patient is not symptomatic, don't do anything. Just wait.
Yeah.
Follow with calprotectin and repeat endoscopies.
Okay. Next question is, in certain cases, we want to start with biological agents, okay, in cases of Crohn's, and we are still on a very weak ground to rule out tuberculosis altogether. So how would you manage such cases? Would you like to start them on ATT?
So for biologicals, one of the recommendation is, even in India, definitely look for active tuberculosis in abdomen and everywhere else, and also look for latent. So here comes the importance of quantiferon gold, etc. Even in presence of latent tuberculosis, in Indian scenario, before starting biologicals, it would be worthwhile treating this as latent tuberculosis and then starting with the biologicals. There is no concept of simultaneously giving biologicals and ATT. You don't give biologicals with ATT.
Yeah. So
in full, so in situations where you have to give, you will still like your patient to at least complete, if I'm not wrong, 6 to 8 weeks of ATT before starting him on biologicals.
Okay. The other next question is stricture of bowel. I do not know the name of the doctor because his identity is not there. So somebody has asked stricture of bowel, how to manage. Would you like to dilate, or would you like to put a stent?
You don't put stents in large bowel unless it is malignancy. and that too left side. Whether you dilate this or ask for surgery would depend on many things. What is the exact morphology of the stricture? What is the cause of the stricture, etc., etc. But you don't ask for stents in large bowel without malignancy, and that too palliative.
Next question is again of practical importance, and it says, my patient is on aspirin and a colonoscopy shows an ileal ulcer. I'm not able to stop aspirin or clopidogrel for that matter. How do you manage?
So is he talking about NSAID ulcer? What is the discussion here?
Written so, but NSAID ulcer is of course a possibility in such case.
So usually aspirin per se does not lead to, it is abuse of NSAID which results in this.
Yeah. So we stop unnecessary NSAIDs in this patient. Then there is a good question. It says, what is the importance of reporting of mesothelial cells in ascites? Sometimes they are reported even in.
I'm not aware.
Yeah, mesothelial cells are the normal cells shed by the peritoneum. So they are normal cells, right? So there is no disease attached to them. And the last question, I think before we wind up, is 23-year-old male with ulcers in ascending colon and transverse colon could not be differentiated whether it was TB or Crohn's. He started on ATT, but during follow-up colonoscopy, he has developed transverse colonic stricture. So endoscopically, he has not improved. He has
No. I'd like to differentiate it. So Dr. Arun is saying transverse and ascending colonic ulcers.
Yes.
So we need to look at endoscopic healing of ulcers. Now, if my endoscopy tells me that transverse colonic ulcers have healed and there is a stricture, this would be a fibrotic stricture. I'll say there is endoscopic healing. So I'll not be able to look here at the ascending colon or image or endoscopically. I'd like to repeat a CT, compare the CT in terms of evidence of healing in inflammation, reduction in inflammation. I'll look at my CRP. If there is evidence of healing, this probably is tuberculosis and the stricture is fibrotic stricture secondary to healing. Continue ATT and dilate if needed. If there is no evidence of healing, reduction in inflammation, this is likely to be Crohn's. Start managing Crohn's.
So, right. There's one more question. I think the last question is any other question he can ask or post it right away. 53-year-old male, chronic diarrhea and fever, ileocecal involvement. Patient has started ATT, is on ATT for last 6 months. Symptoms improved, gained weight. After 2 months of stopping ATT, he again started having pain, abdomen, fever. Colonoscopy revealed multiple ulcers and biopsy, again suggestive of colitis. So what is your take on this situation? That after stopping ATT, after giving it for adequate duration of time, 6 months, he has relapsed in terms of symptoms as well as colonoscopic ulceration.
So if to start with, the diagnosis was not based on microbiological evidence, that is, gene expert was negative, there was no culture or caseous necrosis on biopsies, that is, it was presumptive tuberculosis, then for all practical purposes, this patient is not tuberculosis and is likely to be IBD and should be started on treatment of IBD. That AIMS paper, which I discussed this, which they said around 35% of their patients of Crohn's disease clinically responded to ATT, and 80% of them, after clinical response, relapsed within a year. So, if your diagnosis initially was microbiologically proven tuberculosis, you are dealing with a possibly drug-resistant tuberculosis. It was not a microbiologically proven tuberculosis. This is likely to be IBD.
Okay, and last question is again atypical. Is there any atypical TB or bowel? Well, I don't understand the question. atypical, what he means by atypical
We must
tuberculosis?
be talking about atypical mycobacteria. Normally, in immunocompetent individuals, we do not talk of atypical mycobacteria. This entity is very commonly seen in post-transplant HIV or chemotherapy patients. Yes, it is there. The presentation and management is totally different.
Yeah. I think we should now limit the questions to this last. Should be the last question. Otherwise, you can post your questions on the group, and Dr. Mittal will answer them. The last question is: we have a patient of cirrhosis with low albumin, low platelets, and he developed tubercular ascites. He has received ATT for 18 months, which is surprising. Generally, uh, I think there is no recommendation to extend the duration of ATT if patient has cirrhosis. Rather, you should be very careful. So the question is, ascites shows now lymphocytic predominance, low SAG, ascites is still persisting with features suggestive of tuberculosis. What is your recommendation?
So what I can gather here is it is a low SAG ascites is somebody who is cirrhotic. So if I take that low SAG ascites not responding to ATT, lymphocyte predominance, I'll ask for this is unlikely to be tuberculosis. After having received 18 months, uh, I'll ask for malignant cells cytology with a cytospin. Ask for a CT again to look at if I can biopsy something. Ideally, this patient needs a laparoscopy, but yes, I like to confirm my SAG once again. If it is a borderline SAG case, if it is a situation where the lab might be causing a issue, I like to repeat my SAG once again and to be very sure on SAG. If the term here becomes high SAG, then I just say it is a ascites secondary to cirrhosis, and you just need to continue diuretics and nothing else.
So in my clinical experience, I'm not quoting any paper or recommendation. When I treat my patient with diuretics and you do another ascitic tap in follow up, you find that lymphocytes have increased, maybe because of the diuresis, and SAG is of questionable value when the albumin is very low. So these two things you should keep in mind. Uh, Dr. Vibhu, is there any recommendation to extend the treatment in immunocompromised patients like HIV beyond
Sir,
6 months?
the recommendation which I could get through was not for children and not HIV. So it was for immunocompetent. For immunocompromised individuals, I am not the right person to talk on duration of ATT, etc.
Yeah, okay. So, right. I think that was a wonderful session. Lot of learning, especially for me. Anybody else who wants to say anything, please. Now you can
So, sir,
unmute and Pankaj.
hello, sir.
Hello, Pankaj.
So I'm just listening. Actually, it's a very fantastic, session. There were some queries were put on, right? So I just wanted to, clarify these things. There are issues of fluids, right? You said at ascitic fluid, a pleural fluid, a CSF fluid, ADA, right? So there are different values in different fluids, right? ADA in ascitic fluid will take a cutoff around 30. In pleural fluid, we take a cutoff of around 40, and at CSF, we put a cutoff around 10 or 15, right? So there are different cutoff values, different fluids. Secondly, the gene expert is a very poor, specificity in fluids, right? We don't actually go for this gene expert in fluids. It's a very low specificity. So in fluids, ADA definitely is very, very important. With other clinical features are present. ADA is a very important, feature of ruling out or ruling in tuberculosis at times. But for example, in a fluid, like suppose in pleural fluid having empyema, suppose, right? So we take this gene expert, the sensitivity, the specificity increases, right? So regarding second, thing on this rifampicin, right? So it is very clearly said that in extrapulmonary tuberculosis, the resistance, the prevalence of resistance is very low. Extrapulmonary tuberculosis, the MDR, the prevalence of MDR tuberculosis is very low. In pulmonary, it is high, but in extrapulmonary tuberculosis, it is in India actually. In India, is very low. So we take as every extrapulmonary tuberculosis is sensitive treatment rather than MDR tuberculosis, and we take rifampicin as because it detects gene in that gene expert, right? And it is said that if it is rifampicin resistant, it would take in as the sign resistance also. That is a defined. That is what we defined as MDR tuberculosis. Okay. And regarding that last question that comes, like regarding this revised national tuberculosis program, the duration of ATT in immunocompetent and immunocompromised patients is the same, right? If you treating HIV patients with tuberculosis or non-HIV patient with tuberculosis, the duration is the same. There's no issue regarding that you have to extend the treatment for tuberculosis in immunocompromised patients. That's for sure.
Yeah. Pankaj, can you explain me why neurologists or neurosurgeons extend their ATT to 18 months?
Right. It's actually all like personal bias actually, because previously
what I've read,
yeah,
the penetration of ATT to bone and CSF is low as compared to other regions of
right.
the body. That was the one explanation given. And secondly, they want, but a patient becomes bacillary negative in any case in about 2 months' time.
Okay. So, sir, the recommendation that because I have last year I've done a course in tuberculosis from revised national tuberculosis program in Chennai based. So what they recommended now that the duration of this CNS tuberculosis is 12 months, right? Is 12 months, and you can extend to 15 months at max, not 18 months, 24 months. So most of the CNS tuberculosis is getting treated in 12 months time, right? Because of the low penetration of few drugs in the CSF. Okay, but the maximum duration would be around 15 months, not 18 months, sir. Right? Okay. That is a recommendation, and it is equally good for bony tuberculosis also, because most of the patient or this orthopedics they continue for treatment for 18 months to this 24 months. But it is also said that maximum duration of treatment would be around 15 months for both CNS and bone tuberculosis.
Okay. One thing, the one statement which you made right now is that if there is resistance to rifampicin demonstrated on gene expert, we assume that there is resistance to INH also. Is that right?
This is very true when we're treating as extrapulmonary tuberculosis, because in EPTB the resistance or rifampicin is very low, sir. We don't find any resistance to rifampicin. But if there is, because MDR tuberculosis defined as resistance to both rifampicin and INH. Okay, if we define MDR tuberculosis, so it is taken as it is. Yeah.
No, it is assumed, but
it is assumed, sir.
In practice, if the gene expert shows resistance to rifampicin, you will also like to discontinue INH on this assumption?
No, sir. The guidelines says that you don't, because it is presumed. It is not because gold standard is cultures. Right, if you are reference resistance, definitely you are going for the cultures, right? If the culture says okay, it is resistance to INH is fine, but you make out sensitivity to INH also. But normally, as it's presumed that if it is resistant to rifampicin in gene expert, it is resistant to INH also. Yes.
So you would like to start at least 4 or 5 drugs other than INH and rifampicin in such scenario, even in abdominal tuberculosis.
Although this is the standard of care of treatment for MDR tuberculosis. That you have to start. Yeah, this is standard of care for both pulmonary and extrapulmonary tuberculosis.
But we don't see many MDR.
Yes, very true, sir. We don't see generally, sir. Yes, sir.
Pankaj, thank you for your contribution. I think it's already past 1 hour.
Right, and a very important, sir. I want to put a comment on that, because this patients coming to your OPD or any OPD of clinicians or general practitioners, the abdominal pain is very important. In abdominal pain, the most common complaint that person comes to abdominal pain, recurrent abdominal pain, no signs, no localizing sign, and sometimes they go to general practitioners and they start ATT, right? Suppose they get an ESR done or some this Montus done, on that they start ATT, right? And ironically the patient actually improved. Mm-hmm. So one of the patient who comes to me, I got everything investigated, CT, abdomen, everything, but no signs of tuberculosis, and the patient went to general practitioner. He started ATT, then patient went come to me, और सब उन्होंने ATT शुरू किया, मैं ठीक हो गया. So the irrational use of ATT in abdominal pain is actually very rampant in our country, and most of the patients with ESR and MON2s are actually landed is on ATT. That Vibhu also must be seeing a lot of prescription of MON2 positive, or this positive patients put on ATT on no grounds. But now we have tests, sir. We have tests now. We have ultrasound guided test, and we have other tests. We now take a tissue biopsy. The tissue diagnosis is very important to label as a patient of tuberculosis, and I think we should have a tissue diagnosis before we start this patient ATT. Therefore, we can have eradication of tuberculosis by 2025. Then.
Yes, I think your comment also reminds me of my teacher, Dr. Pamra, SP Pamra, who was director of New Delhi Tuberculosis Center, which was next to our LNJP hospital. Okay,
Sure.
And we were posted there as students, as interns. And there was no ultrasound those days, no CT scans, almost no FNACs. Everyone used to start ATT after seeing the patient for 2-3 weeks. When not improving, start ATT. So what he told us, that 70% of cases in who are coming to New Delhi Tuberculosis Center do not have tuberculosis. I mean, 70% of patients on ATT do not have any evidence of tuberculosis. So I think this kind of practice is staying there because we don't have control on our fellow physicians. Anybody can start ATT, anybody can tell patients anything. But scientifically, we should not do that, certainly.
In fact, the recent program for tuberculosis, but 2025, now they have eradicated term like eradication, tuberculosis eradication, this TORS program, something like that, so that you can start ATT on presumptive basis also. Before it was that okay, it is DOTS, it is specimen proven or smear proven. Now you can start ATT on a presumptive test, and you have to notify to the government authorities. So it's now very easy to start ATT now.
Pankaj, are you routinely notifying, filling up those forms?
Yeah, yes, sir. Yes, sir. We have people are there at place. They are from JEET organization, right? So in IMA, what I've done, I made a whole group of IMA with TB notification. Any patient who have TB notification, post the patient's credentials on that group, and that will already notified by the JEET people. So JEET people are on our behalf in notifying this thing. We are not doing any paperwork. They are doing on our behalf. That is a program that is running in our IMA. So it's very good because sometimes it's very difficult to fill the form and put into the app, because there's an app also that you can place all these things, Aadhaar card number. Sometimes it's very tedious in a busy practice.
Yeah,
So
can you WhatsApp the number of that particular?
Yeah, sure. So JEET people are actually doing our notification on our behalf, and it is now a legal thing. You have to notify every tuberculosis, be presumptive or be probable or be confirmed. It has to be notified, sir.
Okay.
So any patient on ATT has to be notified, sir.
Right.
So I'll provide the number, sir.
I think I must thank everyone, every student, the speaker, Dr. Vibhu Mittal, Dr. Pankaj, and Dr. Sushil Ratan actually joined from USA. He left after 1 hour of listening, and in fact, in his comment, he has congratulated Dr. Vibhu for his excellent talk, and so do we. Dr. Vibhu, are you there?
Yes, sir, I'm there.
Okay. Thank you very much. It was a fantastic talk, great learning, and we now meet next Sunday. Next Sunday is hepatorenal syndrome by our nephrology team. Again, a source of lot sorted out in next talk also. Thank you very much. Thank you.
Thank you, sir.